Hi, I'm Dr. Ken Sharlin. I'd like to talk to you today just a little bit about the disease multiple sclerosis because as a neurologist and particularly one who integrates both functional and regenerative medicine with traditional neurology, I see a tremendous amount of multiple sclerosis. We do a lot of work with Dr. Terry Wahls. Some of you may be familiar with the Wahls Protocol. She and I collaborate and she sends me patients. I do see quite a bit of MS in my clinic, and many people travel to see me in Ozark, Missouri, and work with my team in order to benefit from a really complete approach to multiple sclerosis. MS affects at least 1 million people in the United States. We do sometimes see someone with a family history who has multiple sclerosis. They themselves have MS. It turns out that the contribution of genetics to multiple sclerosis is actually really a small portion of the overall picture. For example, if you have two identical twins, and that means they share the exact same genes, one happens to be diagnosed with multiple sclerosis, the chances that the other will develop MS is only about 25%. That really means that environment and lifestyle plays a huge role in determining whether or not a person might develop MS, in addition to some genetic or biochemical predisposition. There are other factors that are important to the risk of MS, includes things like low levels of vitamin D, exposure to the Epstein-Barr virus, obesity in childhood, cigarette smoking. Those are some other common or well-known risk factors. MS does affect women a little more often than it affects men. Unlike a lot of the diseases which you might call diseases of aging, such as Alzheimer's disease, Parkinson's disease, MS is really a disease of young people. There are always exceptions to things we really see across the chronological ages, not just people who are older, but unfortunately we do see ALS in young people. MS is really a disease of young people. It's actually not terribly uncommon to see a pediatric case of MS, although that's not the emphasis in my clinic as an adult neurologist. I think the average age of onset is around 34 years old. Some people want to know if their MS will ever go into remission. Studies have been done, and there are ongoing studies looking at the natural history of MS. The person with MS who's taking some of these very powerful medicines to control their disease that we call disease-modifying therapy might eventually be able to just discontinue their medication altogether. And I'm talking about someone who is not necessarily participating in a functional medicine or brain tune-up oriented lifestyle medicine program that we offer at Sharlin Health and Neurology. In other words, if we do nothing but take the medicine, make no other changes, what is the likelihood the person will eventually go into remission if by age 65 the person's had no evidence of disease activity either clinically or by way of their MRI within about a 12-month window? They probably really are in remission and could likely successfully stop their disease-modifying therapy. If you do take more of a functional and regenerative medicine approach, addressing cellular health, getting into the nutrition piece, sleep, movement as medicine, stress resilience practice, very important to build up that muscle, and even your connection with others, taking that deeper dive into the type of labs that we do in the Brain Tune-Up program will really give you that extra edge. You're doing is trying to ultimately stack the odds in your favor that your disease will be well controlled, and that's well controlled either without medicine. Some people really still do need the medicine, but without integrating the functional and regenerative medicine approaches, they do not do nearly as well. The medicine really only at best 50 to 60% of the time slows disease progression. We really look now primarily at sustained disability, meaning historically, if we think of the most classic form of MS called relapsing remitting, where the person essentially has attacks of symptoms, they may be treated with intravenous steroids, a drug called solumedrol or methylprednisolone. They expect that those symptoms will resolve or largely resolve, but the problem historically with MS is that these attacks become cumulative. So every time you have an attack and you don't completely recover, It just adds to that burden of disability until the person is having to use a cane, a walker, or a wheelchair. In some cases, they become completely bedbound. There have been lots and lots of strides in the area of MS, and I see much less of that advanced disability than when I first started as a neurologist back in 1993. There's a tremendous amount of hope, and as a matter of fact, it's said that the life expectancy now for someone with multiple sclerosis is only about 5 years less than the average life expectancy of a person living in the United States without multiple sclerosis. If we want to all live as long and as healthy as we possibly can, this just speaks to the tremendous strides that have been made in the conventional treatment of multiple sclerosis. You want to take it to the next level. You don't want to be completely dependent on medicine in the passenger seat of your illness. You want to be in the driver's seat of your illness, making the decisions, being much more in control of what's going on. Let's talk about the brain first in general. The brain is kind of like the deck of the Enterprise, the command deck where, Captain Kirk or Luke Picard sits at the captain's chair and runs all of the programs, all aspects of ship's operations. That is your brain. If we compare the brain to the heart, and there's certainly plenty of heart disease out there, if you think about it, there are only 2 or 3 ways that someone who has heart disease really becomes symptomatic. They might have chest pain, that's very classic, and especially shortness of breath with physical exertion. The heart is basically a biological pump. No matter what kind of disease you have related to your heart, and we commonly talk about things like coronary artery disease, whereby an artery that supplies the heart muscle itself becomes narrowed or blocked, and that leads to a heart attack. There are many types of heart diseases, congenital heart disease that you're born with, you have your chest hit very hard, or you could have a cancer of the heart. They're not that common, but they definitely exist. You can have inflammation of the heart itself called myocarditis, or the sac covering around the heart called pericarditis. No matter what type of disease affects the heart, it's chest pain, it's shortness of breath, maybe palpitations, racing heart, slow heart. Let's think about the brain. Again, command deck of the Enterprise. Your brain does for you, from touch to smell to thinking to speaking, everything that you experience through all of your senses, and then everything that the brain executes from movement. It's not just raw muscle power, but it's coordination, it's grace, it's being able to move across the room, to walk across the room without necessarily having to think about which muscles you need to engage and how much you need to engage. That, of course, happens automatically. Very often I have consults that are referred to me in my office, and I call them, you might have MS. MS, because very often tend to be women more often than men, because women have MS more often than men. They are fairly young, because younger people tend to be affected by MS initially. That doesn't mean that you can't have MS in your 40s or 50s, but chances are if you have MS at that age, most of the time you probably had your first lesion or your first attack at a much younger age. There's that spectrum of symptoms from visual changes to loss of sensation or numbness or creepy crawly feelings or weakness or incoordination. These are common symptoms. What we really need to be thinking about is that these are brain symptoms, not diagnosis symptoms. Your primary care doctors, primary care nurse practitioners, or emergency room doctors referring you to a neurologist. And of course, that's entirely appropriate. But we have to remember that not all numbness is MS, not all pain is MS, not all visual change is MS, not all difficulty getting your words out is MS, not all weakness is MS, not all incoordination is MS. How do we make the diagnosis of multiple sclerosis? And this is really critical. And it's important to understand that, like a lot of diseases that neurologists or other doctors diagnose and manage, there are specific diagnostic criteria. We don't just pull the diagnosis out of a hat. What are the current diagnostic criteria for multiple sclerosis? They're called the 2017 Revised McDonald Criteria. It was originally published in the British journal Lancet. At the center of this diagnostic criteria, at the core, is really this idea that the symptoms and signs, what we sometimes call lesions, or those spots on the brain and in the spinal cord, are separated by space and by time. MS is a disease exclusively of the central nervous system, meaning brain and spinal cord, but not peripheral nerves, not muscles, etc. Those are all outside the central nervous system, all the way down to the tail end of your spinal cord, about 2/3 down the way of your back. I have a lesion up here, but I have a lesion down there. Those lesions are separated by space. And very often what we call a lesion to a neurologist kind of just means a spot or an area that's affected. They consist of a variety of changes where there's inflammatory changes, there's destruction of the fatty coating around the nerve cells called myelin. We sometimes call MS a demyelinating disease. And actually there can be attack on the nerve cells themselves, or the axons. If much of that occurs, then really that area of brain ends up being destroyed, or spinal cord is destroyed, and the inflammatory component goes away. Unfortunately, what's left is a big hole, and that's why sometimes these are called black holes on MRI. If you look at the brain on autopsy where there have been a lot of lesions like these, it sort of looks like Swiss cheese. So we definitely want to avoid things that are that aggressive. Think about the separation of space and time. So by and large, if you had a single lesion in the brain that was sort of reminiscent of MS, would that be enough to meet the space criteria? And the answer is no, it would not. The MRI does become very important in establishing that physical space. The revised McDonald criteria incorporates discrete attacks, so we can understand attacks in terms of not just what part of the body is affected or what symptom presents as, such as visual loss in one eye. Painful visual loss is called optic neuritis. A person can have optic neuritis by itself, but optic neuritis is often part of the spectrum of what is MS. They have a single lesion and no evidence of prior lesions, no evidence of other changes, they wouldn't be said to have MS. One or more attacks or one or more lesions, and the presentation on the MRI that we can understand that they have occurred in more than one area of the brain. Now, what about time? MS often presents as what we call relapsing remitting. That means that you might have an attack one day and it lasts several weeks and then it goes away, and then 2 years later, maybe you have another attack, or 3 years later, and so on. The other core feature, separation by space and separation by time. Everyone with MS eventually just presents, will have their first ever attack. It's kind of like migraine, where a person has a history of migraine headaches. Technically, the definition of migraine at least requires 5 or more attacks. Does that mean that we have to wait for them to have 5 attacks to say they have migraine? They, of course, have a complete neurological evaluation to exclude other things. The people with MS will have their first ever attack by and large. We go through the physical exam looking for clues to localize findings in physical space, meaning brain, spinal cord. Sometimes you can have these spots or lesions or plaques appear in the brain. They just come and go, absolutely no symptoms. If there's evidence, say, of one of these lesions in conjunction with an attack, and maybe we know that it's recent because when you got your MRI, they gave you that IV medicine called gadolinium, the contrast used for MRI, and that lesion lights up, meaning there is breakdown of what we call the blood-brain barrier. There's acute inflammation, but you have other lesions that don't light up. That suggests that they are older. There is a separation of time that way. The McDonald criteria allows for is that spinal fluid can be examined. We specifically look for what are called oligoclonal bands. What this represents is an immune response that is taking place in the central nervous system that is not taking place in your bloodstream. You could have a systemic viral infection like COVID and potentially have immune globulins that show up in your spinal fluid and show up in your blood. That would not be oligoclonal bands. We always draw a tube of blood when we check your spinal fluid for MS and test for oligoclonal bands, because the blood has to be normal or negative compared to the spinal fluid. Oligoclonal bands, these unique immune globulins or this immune response in your central nervous system, characteristic of MS, and a history that supports the diagnosis and a physical exam that supports the diagnosis, then you have multiple sclerosis, the space and time criteria. Again, the presence of oligoclonal bands is a way to establish the time dimension that is required for the diagnosis. If there is suspicion of MS, I want you to see a neurologist. You're not going to be self-diagnosing too often. It can be a very dicey situation for everyone involved, especially you. Please don't self-diagnose. Be informed, but don't self-diagnose. MS has very specific criteria. The MS is dependent upon demonstration of both clinical attacks or lesions, unless you have progressive MS, and the presence of these lesions on the MRI, especially if one is enhancing, and potentially the presence of what are called oligoclonal bands in your spinal fluid. And all this is done to establish the space and time dimensions that is at the core of the diagnosis. So just having numbness or visual change or weakness or pain or feeling like you're off balance or feeling like you have brain fog, that is certainly to be taken very seriously, but that does not mean automatically that you have MS. Please do see your neurologist, see a doctor, get a proper workup, which does include excluding other diseases, 12 deficiency, Lyme disease, something called cardiolipin antibody syndrome. We really have to take into account the whole picture before we make the diagnosis. It is not simply a symptoms-based diagnosis. Again, it's based on the 2017 revised McDonald criteria. So I hope that was helpful. If you do need more information, support from me, support from my team, please check out our website, functionalmedicine.doctor. Schedule a complimentary 15-minute consultation. We'd love to see you in the office. We'd love to work with you and really love to offer you the full range of services that really truly makes our clinic unique, not just the general neurology part, but the ability to integrate principles of functional medicine into your neurology experience so that you have our unique brand of neurology called Brain Care. Have a wonderful day. I'm Dr. Ken Sharlin. I'll talk to you soon.